Good evening, everyone, and welcome to this webinar entitled Multimodality Cardiovascular Imaging Training Challenges and Opportunities. It is my distinct honor to welcome and introduce our distinguished panel and moderators to this webinar. The cardiovascular, I am Marcelo Di Carli. I'm the chair of the cardiovascular imaging section of the ACC, and I welcome the opportunity to continue our dialogue talking about training and multimodality imaging training in cardiovascular imaging. The moderators for this webinar will be Dr. Hina Patel, an advanced imaging fellow at University of Chicago, and Jordan Strom, an assistant professor of medicine at the B.I. Deaconess Medical Center in Boston. We have a distinguished panel, Dr. Jim Arrighi, who is past president of ACC, the ACC Competency Management Committee, Ron Blankstein, a professor of medicine and associate director of the cardiovascular imaging program at the Brigham, Harish Jarrett, who is an advanced imaging fellow at Lankeman Heart Institute, Dr. Chris Kramer, who is a member of the board of trustees of the ACC and professor and chair of cardiology at University of Virginia, Dr. Athena Papas, immediate past president of the ACC and director of the Heart Institute at Brown University, Lawrence Rutsky, chief of cardiology at the Jewish Hospital in Montreal, and professor of medicine at McGill University, Lucy Safi, director of interventional cardiology at Hackensack University Medical Center, and Gabi Weissman, who is chair of the program directors and GME Council of the ACC, and a professor of medicine at Georgetown University. Jordan, would you like to introduce the webinar, the objectives, and the speakers?
Thank you very much, Dr. Di Carli. We're very excited to offer this webinar for you. The objectives of this webinar are: 1, to review the current state of multimodality cardiovascular imaging training; 2, to review potential benefits of competency-based training in cardiovascular imaging; 3, to discuss potential models for cardiovascular imaging training; and 4, outline challenges and opportunities for specialty certification. We will start with a 5-minute presentation by Dr. Harish Jarrett, giving the FIT perspective on this issue, followed by a 5-minute presentation by Dr. Lucy Safi, talking about the early career perspective. Following that, we'll have a 10-minute presentation by Dr. Weissman on the results of the latest cardiovascular imaging program survey, and a 12-minute talk by Dr. Arrighi on the benefits of a new paradigm of competency-based training and potential models for that. Following those presentations, we'll have a 20-minute Q&A session, and we'll have time to take questions at that point in time. So with no further ado, I'd like to invite Dr. Jarrett. Thank you very much for joining us.
Thanks, Jordan. Let me share my slides here. Okay, hopefully you guys can see my slides. So I'm going to give you the fellow in training perspective. I'd like to tell you that I have no financial disclosures, but one disclosure is that I'm no longer a fellow in training. Just recently coming out of fellowship. General fellowship ended in 2019 with Gabi Weissman over there, and then finished my advanced imaging fellowship in 2020. So I'm about a year into this. And I think everyone talks about opportunities and challenges, as I've been asked to mention, and often most of the emphasis is at the end there. So there's often challenges, but I'd like to start with the challenges, but then go on to opportunities. They're often the same coin, just flipped either way. You look at it on a different day. One of the issues is that programs are very different, heterogeneous. Not all imaging modalities are naturally offered at each place, and with varied expertise. There's a lack of perceived structure of these fellowships compared to the ones that you've done previously in general. And then modalities are inherently different. You know, vascular studies are very different to cardiac imaging, for example. And in general, you know, training may mean moving to a new place, which is a huge deal in the current era. You know, those are all the same as the other side, right? The programs have unique expertise, is that one way to look at this. One program may have a strength of modality over another, above and beyond any other program in the country at times. A lack of structure actually could be used to your advantage and molded and allow you to mold the fellowship to suit your goals. I don't think there's anything wrong with modalities being inherently different. I think if you know what you're interested in pursuing expertise in, I think that's okay. And then moving to a new place may not be the worst thing and may teach you variations in practice. So I guess it depends on what you're looking at. And I think from a fit perspective, having gone through this recently, what I would say is, you know, do your homework in applying to the correct programs that fit you. And it's a very personal circle and a very personable circle. And if you speak with those of us in the panel, for example, we'll be able to guide you as to, you know, which of these heterogeneous programs work best. Ask yourself what expertise you wish to develop, and ask yourself, does your current institution offer what you're looking for? And most importantly, what type of imager you want to be. I'm going to move on to challenges. So here are some training pathways. You have the aspiring interventionalist, the aspiring EP physician. You all do cardiology training, interventional training, and then you specialize. In the current area, you're going to specialize in various fields. At the end of the day, each one of you will do a certification board exam. So there's one of them for the interventionalist, one for the electrophysiologist. And then I'm just going to give you the heart failure example and then put that side by side with the imager. Heart failure is very similar to other ones. And I think this is where we differ. So the aspiring imager, all of a sudden at the end of their training, is kind of faced with a little bit of an avalanche of training certification. This can be a little bit of a challenge, and I think that's partly why we're having this conversation today. And I think there's room for improvement, or you can look at it in a positive twist as well. There are other challenges. I think not being part of a match system kind of puts the applicant at a disadvantage. There's a lack of ACGME accreditation, which has some issues, particularly to those who are here on visas, for example, and that may be a barrier to access to this kind of training. And then there's multiple certifying bodies. I've put a couple of acronyms up there, which are all genuine challenges. And then within the genuine challenges, there are nuances of challenges. Within the states and even within programs within a given state in the country, level 3 echocardiography means very different things to different people. There's a vast heterogeneity in what level 3 echocardiography means, and where does interventional echocardiography fit in, for example. These are all kind of unanswered or questions that are open to answers that are varied. Cardiac CT and cardiac MRI are fields in evolution. The board certification is in its infancy, and we've been some of the first cohorts to take these tests, for example. Equipment plays a big role, and I've learned that firsthand, having trained and now working in a place with equipment that differed to where I trained. I think these are all genuine challenges that should be incorporated into future kind of decision making. And then lastly, I think one of the important things to consider, as with any field, is the life cycle of the workforce entering it. I can speak personally because I am a structural heart to interventional echocardiographer first, and most structural heart programs, I suppose, are now well established and filled, and it may be a challenge if you're thinking smartly about it, applying at the right time in the right place. So These are all things that are challenges for sure. I think there are opportunities to simplify certification. We'll talk about that as we move along. And then there should be a move away, at least an attempt to move away from just a simple log to a competency-based approach. I think so. Those are my opportunities and challenges in a nutshell. Thanks very much for listening, and I'll move it along.
Thank you, Dr. Jarrett. That was wonderful. Before we move on, I just want to remind the audience or those who may have just joined us that if you have questions or comments, please feel free to post them in the chat box and we'll address them after the end of the presentations. And so now that we've gotten a flavor of the imaging landscape and the challenges and opportunities from a trainee perspective, let's take a look from that of an early career perspective. I'll go ahead and hand it over to Dr. Lucy Safey.
Thank you so much for the invitation. It's really an honor to be with the whole panel here and to discuss the early career perspective on multimodality cardiovascular imaging. I have no financial disclosures. I just wanted to say that I am in my early career about going on 5 years now out of advanced echo fellowship. And so I think that this is very suitable in timing. And I wanted to focus the difference between multimodality and single modality imaging. As Dr. Jarrett talked about, during general cardiology fellowship, we are trained in all 4 of the imaging modalities. But what happens when you become an attending? What opportunities are out there for you when you graduate, and what are the challenges in the job search today? And so we're trained in general cardiology fellowship on all 4 modalities, as previously stated, and additional fellowship training can be obtained in all of these. So when we talk about multimodality imaging, we usually refer to CT and MR training, and getting that level 3 training, which was discussed previously, is usually done by people who want to run a lab, direct a lab, and train and certify others in that particular competency. So, for example, CT, MRI are usually intertwined and married in some post-fellowship training programs. They're usually combined. However, if you have one particular interest in just CT or just MR, there are sub-fellowship training in just those modalities. So as an early career attending, I often get called or asked a question, is it worth it? Is it worth it to do this additional training? And it comes back down to what you're looking for your general career. Are you looking to direct a lab? Are you looking to train others and certify others? And in that situation, then getting that level 3 certification in this particular modality may be worth it for you. And moving on to opportunities, when you think about a job opportunity, it may be intimidating. However, there are jobs out there, and usually the best jobs are found by word of mouth. So it continues to be the best resource for finding a job position. You ask your colleagues, your friends, your attendings if they know any of job opportunities, and then turning to social media can be helpful. So websites such as Twitter, Facebook, LinkedIn, I more and more see jobs being posted on there as well. And also you can reference the online career center websites of the major national societies and cardiology journals, because they too have positions that are available. So when you finish your training, you look at these websites, these career centers, and you try to find the best job that works for you. Things that you think about when you're looking for these jobs are, who's reading the studies, how many studies are you getting per day, certain pathologies are you interested in, you looking to look at HCM center, for example. These are things that you want to think about when you're looking for a particular job, and that transition, you may be trained as a multimodality imager, but really when you think about your overall career perspective, you may be interested in one single modality, and that's okay to focus on just one single modality. So in summary, when we're trained in multimodality imaging, whether it's CT, MR, echo, or nuclear, think about what your overall goal for your career is, where you want to be, and that really should help determine whether or not you want to do an advanced imaging fellowship. There are multiple opportunities online to find these fellowship programs and then a job afterwards. And any challenges that you have in your job search were previously stated by Dr. Jarrett. Look at the resources that you have, whether you have a mentor in your current institution, or use the social media network to really reach out to someone that you feel has a similar situation and similar job that you may be interested in. So thank you.
Thank you, Dr. Safey. That was a really great summary of a lot of the opportunities and challenges that trainees and early career folks face as they start their job search. We're going to turn and shift gears a bit. I'm going to hand it over to Dr. Weissman to share results from the latest CV Imaging Program Director Survey.
Thanks, Hannah, and thank you to the organizers for inviting me to speak here. I've been asked to speak a little bit about two surveys that we ran in the past few years that hopefully can help inform the discussion as we're sort of thinking about imaging training, what are the challenges, what are the opportunities, which I think were very nicely presented by our first two speakers. So next slide, please. And I'm going to speak about two surveys, the first one very briefly, the second one in a little bit more depth, and I'll try to keep it short. So the first survey we ran 3-4 years ago now was not of imaging training programs specifically, but rather of general cardiology training programs. And I'll show two slides that I think help inform the discussion. Next slide, please. So one thing we asked was just in general cardiology training programs, what are you missing? And can I ask you to hit the button one more time, please? And you can see the program said that various things were not available at their institution, cardiac transplant, cardio-oncology, but I will make the point that CT and CMR were not uniformly available. You can see about 20-25% of programs felt that that was not something they could provide during general training. Next slide, please. The other thing that we asked of general program directors were how many of your fellows end up with at least level 2 training, meaning able to independently interpret and perform imaging studies. And you can see that there's a great deal of variation. Purple means more, blue means less. And you can see no great surprise, I would think, that if in echocardiography and in nuclear cardiology, the vast majority of programs were training folks directly out of general cardiology fellowship to be level 2 trained, be competent to interpret and perform imaging studies. But when you look at cardiac CT and cardiac MRI, the numbers were flipped. That was not a uniform experience. And I don't think that surprises us, but I think that that helps inform us as we think forward as to, well, what does it mean to be an imager and what does it mean to have an imaging fellowship? Because people show up through the door in various different ways. Next slide. So with that in mind, what we concluded was that there was significant diversity of experiences in general cardiology fellowship. So the next step was to try to find out what was going on in imaging training programs. And as Dr. Jarrett mentioned, that's a much harder thing to figure out because they're not ACGME accredited. There is no master list of these programs. Now, the ACC has done a pretty good job of trying to corral all of these programs together, and we used that list as well as others to try to reach these programs. Next slide, please. So we found 66 cardiac imaging programs nationwide. That included 2 in Canada, and the rest were in the United States. And you can see we got a pretty good response rate. About 76% of programs responded. And it's important to note here that the people that we were reaching out to were program directors of imaging programs. So this is not the fellow's perspective, rather it is the program director's perspective. These programs represented about 151 fellows and a fairly diverse group of individuals. As you can see, at least when it comes to men and women, you can see though that the vast majority of these programs are training cardiovascular trained individuals. So most of these programs are not really cardiology and radiology, but rather predominantly cardiology, and I think that's important for us to remember that we're not, that there are other people involved in this field as well. Next slide. So when we asked training programs what imaging modalities they trained individuals in, you can see again there was some splay here with CMR being almost uniformly available. Interestingly enough, CT was 90% of programs, and then echo and nuclear was less available. And there could be many reasons for that, and we can discuss that later if people are interested. Next slide. We asked program directors what were their challenges there, and I think they reiterated many of the challenges that you heard our previous speakers discuss, from board certification, ACGME accreditation, funding, and also importantly length of training. You know, people are having to do medical school and residency, cardiovascular training, etc. It just keeps on going. And the last one I thought was very interesting. Cardiovascular imaging is not recognized as a distinct specialty, and I think Dr. Jarrett showed that well in his slides. Next slide. We were interested in the job market. What happens to people when they graduate from imaging fellowships? Do they get a job in imaging? And what we found was that the vast majority do. You can see about 90% of individuals had a job where imaging was a big part of what they do, whether it was primarily imaging and secondarily clinical, or primarily clinical and secondarily imaging, but very few people were only imagers or only clinical cardiologists. Most people had blended positions of one sort or another. Next. So I'll just finish off with a quick set of conclusion slides just to go through the overall findings here. So again, we're a large training group. 151 trainees are the third largest pool of trainees, a little behind interventional and a little bit behind EP. A very diverse group of individuals with a strong job market. Most trainees found jobs that required their imaging skill set. Next. We identified 66 programs. As you can see, CMR, CT, and ECHO are the most commonly offered modalities, and programs are very diverse if they were not similar one to the other necessarily. Next. I didn't really mention too much about this, but I'll just mention the program directors are an experienced group of people. You can see the median years since completion of training was 15 years. So the imaging program director is an experienced physician and an experienced imager. Next. And the challenges identified by program directors were diverse funding sources, usually relying on the institution or department, multiple modality-focused imaging certification exams, and importantly, lack of standardization of training, particularly the role of multimodality imaging training. With that, I'll stop and give back my time. Thank you.
Thank you, Dr. Weissman. That was a wonderful summary of all the results that you found. It seems that the heterogeneity of training multimodality imaging has been a common challenge that's been mentioned by all of our speakers. So with that background, I'll turn it over to Dr. Arrighi to discuss potential training paradigms, specifically in competency-based training.
Thank you so much, and those presentations so far have been wonderful. And my intention with this presentation is really to open everyone's minds about possibilities that are introduced when you move to a competency-based medical education format and build on what other groups have done in other specialties outside of cardiology and outside of internal medicine sometimes. Next slide, please. So what are some current and future directions in graduate medical education? Well, certainly there's been progress towards competency-based medical education, which maybe when it was initially put forward got sort of a bad name because no one really knew how to do it. But I think it's becoming more of a reality now. There is an intense focus in the medical education world at all levels on making the transitions from one phase of medical education to another more seamless throughout the spectrum. And I think we have to consider that because in some ways, when you're moving from general cardiology to imaging, that's a transition of sorts, right? Similar to other subspecialties of cardiology. Enhanced flexibility of training to align with career focus is a trend in education now. Creating a more cost-conscious paradigm that's more resilient to threats on DME funding and is sensitive to the financial pressures on hospitals. You'll note that Gabby just said that funding was one of the major things that was a barrier to imaging paradigms, imaging fellowships. Addressing additional barriers is important for us to consider. And certainly developing a paradigm that makes it easier to propose new training paradigms such as imaging is a focus for the ACC. And certainly enhanced diversity in training is an important aspect. Training that incorporates wellness and work-life balance and matching opportunities with workforce needs are also important. Next slide, please. So what is happening in competency-based medical education? I just give a few examples here. I want to note that in transplant hepatology, which is a subspecialty of GI, there are now two different pathways. GI is a 3-year fellowship, general GI. And now, if you're interested in transplant hepatology, you have the option of doing a 2+1 paradigm in some institutions or a 3+1, depending on a number of factors. Geriatrics and palliative care, two separate fellowships in internal medicine, have in some institutions have an option to do blended training over 2 years where the specialties sort of merge together and you get trained in a more seamless way in two different specialties. Some of you may be aware that in radiology, when interventional radiology essentially went from 1 year to 2 year because of the sheer knowledge that needed to be gained to be a good interventional radiologist, radiology introduced a pathway that basically integrated residency and fellowship into sort of a 4+2 model. The traditional pathway still exists, but they have this integrated pathway. And the ACGME has been talking about initiatives in internal medicine that essentially talk about these things and promote these things conceptually, that we're blurring the lines between stages of training and enhancing flexibility. Next slide. So I did want to mention, you can just forward one more time to get the whole slide, and one more, that if you think some of these concepts are crazy or difficult, when you're thinking about potentially blurring the lines between training, shortening training in some areas, in the undergraduate medical space, there's been an intense focus on how to blur the lines between the medical school and residency, shorten training paradigms, and these are coming to fruition now at many institutions that I listed on the left. The benefits based on the initial feedback have been that individualized training pathways have been created. It addresses workforce needs, especially in this case, in the primary care arena, and there's cost savings. Potentially to this, whether it's in the GME space or the medical school space, cost savings and less debt to medical students. And these, and all of these programs, the initial feedback has been positive. The world is not falling apart because individuals are beginning to think about new ways to train. Next slide. So what is the vulnerability in cardiology? I'm not going to belabor this. I think you all know that the length of training is very, very long, among the longest in GME. Is when you tag on a subspecialty. And Gabby already showed this exact data from the survey. But some of the issues that we can address can be addressed on this list. Next slide, by competency-based training. So the goals of competency-based training, apart from just moving towards a true competency-based education, which in theory should result in better education, more focused on the individual's goals, but certainly decrease costs of training, improving transition between stages, increase diversity and well-being, and not just of our trainees, but subsequently, and to facilitate the growth of cardiology subspecialties. Next slide. Next slide. And just cycle through this until the one more. So the proposal that has been put forth initially for electrophysiology that is pending, if you look at the top panel, this is our current model: 3 years of internal medicine, 3 years general cardiology, and then subspecialty training, for example, in electrophysiology, adult congenital heart failure, et cetera. The competency-based medical education proposal that, again, has been put forth just as an example with our electrophysiology colleagues, but that could be applied and we hope is applied to other paradigms, including imaging, is that you have two possible pathways. The pathway B is sort of what the current model is, which may be an option and of benefit for many fellows, depending on when they choose their specialty of cardiology, when they choose what subspecialty they want. But pathway A is being introduced as an option where essentially the third year of cardiology becomes a blended year that's mostly focused on what one's ultimate goal is in the subspecialty paradigm. You could call this a 2+2 paradigm when you're talking about electrophysiology, for example, or maybe someday adult congenital. And maybe, depending on the paradigm, imaging, because imaging has a unique aspect to it that perhaps might be a situation where some imagers may only need a year training, some, depending on if they want advanced training or level 3, might need 2 years of training. You could see where the options might be several for imaging training moving forward. And the future actually may begin to blend internal medicine and cardiology and blur that interface. Next slide. So the essential elements to competency-based medical education, though, before you even get to that stage, are competency development. You have to define what the field is, what the competencies are, and then assessment methods. Ideally, you'd like to have an assessment methodology in place so that you can move forward. Next. And I think these would be important next steps to imaging, and then you start layering in your discussions about certification and the and how you bring that together, and potentially accreditation through ACGME or not. I mean, remember, ACGME accreditation doesn't come with funding, but it may be, but some accreditations of sorts may be very important to the field. Next slide. I'm not going to point to different aspects of this slide, but when we put forth the proposal for electrophysiology, we being the ACC and the Competency Management Committee, it required a lot of detail, a lot of thinking about what happens at different steps. And this is just kind of gives you a sense of that complexity. Next, but all doable for imaging, all very doable. And I hope I hope rather than confusing you with a bunch of different options, I rather gave you optimism, because there are so many options of how to potentially move forward with cardiac imaging in a number of different pathways and make it a reality that you can match the imaging training to the goals of the individual, something was stated at the very beginning, and maybe even for not all cases, need additional funding for slots and what have you. You may need some slots, but maybe not as many as you originally thought. Thank you.
Thank you very much. That was a fantastic presentation, and it concludes our presentation section of the webinar. We'll now turn to the Q&A section of the webinar. And so you've heard a little bit about the landscape of cardiovascular imaging training, some of the challenges from different perspectives, and also some of the ways forward. And so we wanted to sort of build on that and discuss ways forward a bit with this first question. So this question is specifically directed to Dr. Pappas and Dr. Kramer, which is, we've heard a lot about the financial and time requirements that are ultimately built into having multiple board certifications and maintaining that certification, both from the perspective of training in this, but also maintaining it over the long run in practice. I know this is premature, potentially, and I know the ACC is working on these potential these issues, but what exactly is your thoughts and directions that the ACC could take and lead to help solve some of these underlying issues? Maybe start with Dr. Pappas first, please. Thank you.
Sure. So let's start with the hard questions first, Jordan. Thanks. I think this is really one of the challenges, right? And that is, do you have to be ACGME to be able to coalesce around a single test? And the answer is no. So we've started to have conversations with the multiple groups that you have to go through. Is there a way to bring these groups together to offer certification, whatever it is, but a way to validate both internally and externally to the world that you have accomplished different goals? And I think the other issues that people have raised somewhat in the chat box is, how can you sort of sub-select within there and say, well, I'm doing 3 out of the 4, and be able to test within those areas and show that proficiency. So I think that's a crucial piece moving forward. It's probably more politically challenging, but it doesn't mean that we shouldn't do it. And I think that that's, the ultimate goal is to bring those pieces together. Chris?
And Athena, I completely agree. It would be important to develop a test that would be that a fellow could choose, a trainee could choose, 2 of 4 or 3 of 4, or what have you, of modules. So rather than being required to do all, because not every trainee is going to be able to train in all modalities, and nor probably should they. I think there's some discussion in the chat, that trying to be facile in all four modalities may be overkill, and who has time to maintain their proficiency and really be expert in all four. I think it's probably best for trainees to focus on maybe two, perhaps get trained in three, but really have two that they call their strengths, because realistically trying to maintain proficiency and be expert in four is very, very difficult.
I would add, though, that from a training perspective, there's a lot of advantages to train in all four. And of course, we have a multimodality imaging program. For a long time, we've been really encouraging folks to train in multimodality. And the reason is, as I think everybody on this panel knows, is training in nuclear will make you better at reading MR stress perfusion, and training in MRI, you're going to be better at identifying cardiac masses on cardiac CT. Training in echo will help your MRI. So there's so many complementary skills. And even though most folks that train in all four modalities are not going to use all four of them clinically, even though some do, they're going to be better off for having done that training. So I think at least for the folks out there who are truly interested in multimodality imaging, the goal is not necessarily to go out and read all four modalities, but to get trained in all of them, I think has a lot of value.
It might be worth to rather than say training, words may be important, to say have an educational experience in, and then fill in the blank. Similar to what we do in general cardiology, right? People do caths in general cards who are not destined to do caths.
So that's great, and I wanted to sort of follow up on that by picking out a question from the chat, which came from Dr. Cavalcante, talking about what are the next steps, really from an ACC perspective or ACGME perspective, for the creation of imaging as a unique specialty within cardiology, and what would that require or entail? And I know that's a tricky and hard question to answer, but it's one that we will try to.
Maybe Chris.
Yeah, so it was been worked on for some time. I was Marcella's predecessor as the chair of the Imaging Council in, I don't know, maybe 2011, so 10 years ago. And we looked, there were a number of folks, including Kim Williams and Pat O'Gara, who started to work towards looking into ACGME consideration for an imaging fellowship, essentially. And at that time, there were significant roadblocks in the House of Medicine, primarily, honestly, from radiology. But that was 10 years ago, and so things have changed, and it's certainly worth going back there and sorting through whether ACGME is an option for an imaging fellowship. It is, I think, a bit of an uphill climb, a lot of work to get, a lot of hurdles to go over, but I think it needs to be relooked at.
Yeah, that was a good point, Chris. And this is a subject of the previous summit, as you know, that we had, and will be the subject of many ongoing discussions on how to organize competency-based training, and then ultimately, what is that imaging subspecialty? What it consists of, and how do we certify that people become a special subspecialist in imaging? So it's a lot more to come, and I totally agree that it's really worth revisiting that concept.
Thank you. I'm going to shift gears a bit and direct this question towards Dr. Blankstein. This is an issue that comes up quite commonly. Can you comment on how to balance the integration of radiology and cardiology services with regards to imaging training?
Yeah, no, I think it's a good question. How to balance cardiology and radiology services. I think we can answer that from are you talking from a training perspective or from a clinical practice, or from I think from a training perspective. So First of all, I think there's a lot of value in when you train to train with both cardiologists and radiologists, particularly for cardiac CT and cardiac MRI. For cardiologists, when they start their training, they're going to be at a disadvantage, perhaps regarding things like MR physics or CT physics. And conversely, for radiologists, they may be at a disadvantage regarding some of the, the clinical scenarios and indications. And one of the things that's really helpful, regardless of your background, is to learn what you don't know and learn what you don't have, and put extra emphasis on that. So, if you're a cardiologist and the CT and MR are brand new to you, you've never done that before, you're going to want to spend extra time learning that. And ideally, I think programs that have a good working relationship and train both cardiologists and radiologists, or where the faculty are members of both, I think there's a lot of advantages from a trainee's perspective in such a program. You can sort of learn from the best of both worlds, so to speak. Obviously, the environment is very different, and if you look at training programs out there, some of them are exclusively under cardiology or exclusively under radiology. But really, an advice I would have for folks is if you find a program that there's a good, healthy relationship between the two, I think that would be a big advantage.
If I can just add as well, our program we established, it's important to establish that right from the outset, but we actually have co-readouts of all our cardiac MRIs with a radiologist and a cardiologist. And the cardiology trainees are there, the radiology trainees are there, and you learn from each other, develop that collegiality, you know how to work together. So like you said, trying to find a program where that is encouraged really gives the trainee the best experience.
Great, thank you. So the next question is a little bit about how you incorporate other interests, particularly academic interests, within the clinical training. It's for Dr. Kramer, which is how do you do that? How does one navigate achieving both research training and also clinical training within the same time period?
Yeah, that's a great question. I think it depends on the type of fellowship training experience that one chooses. There are several around the country, and at the Brigham, our institution, some others where there's NIH supported T32 training programs, which are focused on imaging research, where it's 70-80% research time in imaging, and then 20 to 30% clinical time. So and those are 2-year programs. So those are really focused on training academic imagers. But there are other programs that are year-long programs where one can incorporate research into those programs as well. And it depends on, you have to, for trainees, you have to talk to the program directors and find out what those programs allow and entail. And my advice to trainees is really to choose, for research, is to choose one primary modality and one question and merge those two. One can do multimodality research, but usually that is comparing one modality to another. That can only go so far, and many of those studies have already been done. So focusing on a modality and a question, I think, are probably the best use of a limited time during an imaging fellowship.
Great, thank you. This next question I'll direct towards Dr. Saifi and perhaps Dr. Weissman as program director. There's a lot of questions coming in about challenges and opportunities specifically in structural imaging and how to really incorporate that subspecialty imaging within an advanced fellowship. Dr. Saifi?
Yeah, I mean, it's a great question. I think there is dedicated echo fellowships out there. If structural heart imaging, echo specific, is something that you are interested, there are echo fellowships available. And also there are multimodality imaging fellowships that incorporate specific echo training. So really what you're looking for could be out there.
You need to unmute.
Sorry. Basically, I was saying that there are echo fellowships out there, and there are specific interventional echo fellowships out there if you are interested. There are certain multimodality imaging fellowships that focus on CT/MR but give exposure to echo. So really, when you're researching fellowship programs, look and see what modalities are given in order for the fellows to rotate through. But if you're specifically interested in structural heart interventional echo, like I said, there are multiple institutions that have that sub-fellowship available.
I guess I'll add, I mean, I think that's the right thing, is just to realize that when you get to this sort of level of training. Can you hear me okay?
Yeah.
I was just saying that, you know, when you get to this level of training, when you're going for an advanced imaging fellowship, you're really there to acquire a very specific set of skills. And I would urge people to not think about this as level 3. I'm going to be level 3 in these modalities or level 2 in these modalities. It's really the skills and the competencies, to go with what Jim was saying. Different programs are different, right? In some places you'll learn a lot about research. In some places you'll learn more structural, etc., right? You really need to think about what skills and competencies you want for the next stage, and really target your search based on that. I'll take the advantage, just because I have the mic, for 1 second to say that, you know, I see a lot of great questions out there and a lot of great comments, and I also see a lot of great colleagues out there, a lot of program directors and really advanced imagers. And Marcelo knows this sort of point that I have, which is one of the great things for us on the general program director side has been that the ACC has put together a group of us, and we talk all the time, and we ask these questions of each other all the time, and we come up with answers, and we learn from each other. And I would ask the group, you know, what can we do to get the imagers together, and, you know, having these discussions, you know, back and forth in various informal sessions, and coming up with some of these answers to the questions that are out there.
So, Gabby, that was a great point, and one that was discussed at our last call, and maybe a work group across the Program Directors Council and the Imaging Council would be a great way to start, coalescing, you know, the program directors of imaging programs, bringing FITs and early career people also into the conversation. So I think that was a great point, and something that we will do.
That's great. Well, I think a lot of the questions that have come up in the chat and some of the discussion has been around how many modalities is too many to train in and to maintain your expertise in. And there was some discussion in the chat as well about descaling and whether or not individuals who are practicing in general cardiology, not using their imaging training, lose their imaging skills over time. And so this is really a general question, but specifically I'll ask Dr. Jarrett, as you're recently right out of fellowship, how many programs is too many, and what's a good number, and how do you ultimately become and stay an expert in multiple different imaging modalities?
Yeah, it's a challenging question. I think depends on your approach or perspective. My goal was always, personally, was to do with evaluation of cardiomyopathy and evaluation of valvular cardiomyopathy. So naturally, I initially was attracted, no pun intended, towards magnetic resonance imaging. And then, you know, from there it divulged, you know, it diversified a little bit because I realized that valve disease often involves structural interventions, and did advanced echocardiography, and with that came CT, because those are kind of hand in hand these days. So my perspective was, what was I interested in, and how did everything else help me achieve those things, as opposed to how many different imaging modalities could I kind of certify in, and I think that may help kind of crystallize what you need to do if you focus on what exactly it is you're interested in, and then go from there. I'm not sure if that helps or answers the question, but that was my perspective.
That's great in terms of a training perspective. In terms of maybe some of the other panelists might be able to chime in about maintenance of certification and how one maintains that certification, and not just certification, but also skill set in a particular modality over time.
Yeah, I'll jump in. You know, if you look at each society's recommendation for number of hours of CME to, you know, yearly CME to maintain certification and expertise, you know, you'll be traveling 2 months a year to meetings to you know, get your CT hours or your echo hours or your, you know, so it's very hard to maintain certification and expertise in all four modalities. I think, you know, many of us on this webinar, you know, are reiterating that training in all is quite useful, because you learn what different modalities are good and are stronger at and less strong at. But perhaps once you get out of training, that focusing on 2, max 3 is probably easier to remain an expert in those modalities.
I would say it depends a lot on your, you know, your volume. If you have an 80% clinical job and you're doing 1 day of imaging and the volume's not that high and you're trying to spend 1 day of imaging in 3 modalities, it's impossible to keep up with everything. But if you have a job at a high volume center, I actually think that the numbers for maintaining your the ones that Chris was alluding to that societies recommend, I actually think those numbers are really low. Like if you look at like the number of CTs you need to do a year to maintain your credentials, you know, if you're at a high volume center, you can get those numbers in a month easily. So I think it really depends on your perspective. But I think the goal is not just to maintain competency. Your goal is really to be a master, to be an expert, to kind of stay at the top of the field. So I encourage everyone like to say like, how can I stay on the top of, you know, the field and not just to maintain the basics.
Yeah, Ron, just to clarify, I was really speaking of CME, you know, the number of hours of CME, not the number of studies one needs to do a year. Most centers, you know, individual will be able to get those in multimodality. Yeah. But if you look at the number of suggested CME hours to maintain for each modality and you add them up, you know, times 4, it's a lot of hours.
But paradoxically, the place where you might need the multimodality, the four modality imager is the low volume center, where you may have issues of access and equity in the small community hospital, where if you don't have that person who has level 2 in all 4, that patient may not get that test because they may have to travel hours and hours and hours away in order to get it. So it's a bit of a paradox.
Good point.
Jordi and Hina, maybe a question that came via the chat box was, you know, level 2, level 3, and what does that mean in the context of competency-based training? Could maybe ask Jim or Gabby to really try to clarify or begin to clarify, you know, this transition and the terminology for defining, you know, who has the competencies to practice.
Yeah, that's a great question. And you know, this level 2, level 3 paradigm, when you think about medical education more broadly, is unique to cardiology. So it's an interesting concept, isn't it? And I think it was born on this concept of 2 levels of clinical training, and level 3 also introduced administrative skills, research skills, you know, education skills, and that kind of thing. I do wonder if it's a paradigm whose time that maybe needs to be rethought, honestly. And that's just my own personal opinion, because I think, you know, when you think about what trainees are doing and trainees want, it's all driven by something. You have to think about what drives it, and it's either driven by what the chiefs of cardiology in this panel want when they're hiring people, or it's driven by this concept, you know, if I can be trained in echo at one level, but be better trained, most individuals want to be better trained. So I do think it's a paradigm that maybe is whose time has passed. You know, there isn't really different levels of an interventional cardiologist. There really aren't different levels of electrophysiology. There are electrophysiologists that do different things, but we don't talk of them as different levels. So I think it's something the ACC and the educational community could maybe reconsider.
On that note, there was just a question, I think somewhat related to this, which is what might the next COCATS iteration actually look like? And obviously can't foresee the future, but it's, you know, where are we headed? And this is sort of a broad question, but maybe Dr. Pappas, if you have an answer to that, or Dr. Origi, would love to hear your thoughts.
I certainly don't have any insights in the COCATS, and Jim will have more than I, but I think the overarching concept becomes really important, and that's what we've been talking about, is we don't want to build yesterday's model. So we need to be thinking about building people who are competent and have the skills to learn what happens new next year or in 5 years, so that you're a great echocardiographer, and when 3D or structural comes along, you'll have the basis to move to that next level. So that's sort of the way I think about it, and that might be a way that we start to break apart this level 2 and 3. And I think that the COCATS is trying to move away from the numbers and into more competencies. Do you know enough after a period of time to read appropriately and for more complex things? But I'm curious what Jim has to say.
Yeah, I agree. I think, I don't know what the next COCATS is going to look like specifically, but the great advance of the last COCATS was the competency tables. So that set a certain framework that can be built upon to, you know, to move forward. Now, specifically relevant to this group, what didn't work so well in the last COCATS was the multimodality imaging statement, to be perfectly frank. And I think that one of the things that you know, the imaging community with the program director community could do, and we discussed it at the summit, was create a training statement. You know, begin to make these difficult decisions about do you do you know, what's in a 1-year program, what's in a 2-year program, what's there, because you got to have that before you start going to ABIM and ACGME anyway. And I think it would do. I think we're at a time when all the energy here can be captured to. That's not going to be easy, but I think it's time to do it.
Yeah, if I can jump in on that as well, the whole issue of the objective of complementarity, and that's what I'm talking about. And this is really where the whole competency by design or competence-based teaching comes in. We've all been focusing on developing a timeline, but we really have to work on the curriculum. The competence-based training really is based on, you mentioned the words milestones and competencies, but those are real big nebulous things for a lot of people. A milestone, for example, in doing a transesophageal echo is obtaining consent. The second one is intubation. A third one is mapping a mitral valve. A competency is doing a competent mitral valve procedure. But we haven't even started looking at that from the multimodality perspective. We kind of train sequentially. So you do your year of echo, then you do your year of MRI. And, you know, while you're doing your MRI, are you doing echo, which are like the core consolidation year when you've just finished your training. You know, in the core training, when you have your months spaced out, when you go back, you've forgotten what you do. So how do you fundamentally alter the training program? We have a model where we do echo MRI, where we do 3 months of echo, 3 months of MRI, and then for the next year and a half, we do 2 days of echo, 2 days of MRI. And so you really understand, appreciate the complementarity. So there's so much work. You've established that the timelines, trying to contract the timelines, but in order to do that, you really have to completely fundamentally change not only the core cardiology training, but the subspecialty training beyond that.
Thank you. So I have to unfortunately interrupt this lively discussion because the hour is upon us. And I think we've heard fabulous sessions ranging from the challenges to the opportunities going forward in imaging. And this is just the start of a broader conversation. So I really want to thank my co-panelists and all my co-moderators and all of the panelists for being here, and for everybody for joining us at this hour to hear about this. And please do stay tuned for more updates from the ACC Imaging Section. Thank you very much.
Wonderful. Thank you all very much.
Thank you.
Thanks.